This is a very interesting panel. It's in fact a very unique focus on developing capacity and advancing evidence-based practices in the South. And Smart Africa has enabled the development of collaboration between Ghana, Kenya, and Uganda. And with many issues common to all three settings, there is much that I believe that we can learn from research that is being done in these contexts, in these Southern contexts, to strengthen and improve the work that we are all doing on child mental health. I think particularly useful would be the innovations in the way approaches to child mental health have been adapted, whether it is in measurement or programming research design, approaches to working with communities and so forth. And so work that helps us to think about scaling up efforts in scarce resource contexts. And I think that's a sort of underpinning condition here, that these are scarce resource contexts, I think would be extremely helpful in this conversation. And of course, other issues relate to how to influence policies. Our last speaker was significantly speaking to the policies that UNICEF tries to work with governments to influence for advancement of child mental health. And given that we have presentations from Ghana, Kenya, and Uganda, the talk, I think, would be interesting in terms of how one learning in one setting can transfer to another, or can inform practices in another, even beyond Africa, to other southern-based countries. So with that, let me introduce the three speakers who will speak about these issues in various ways. First, we have Dr. Immanuel Asampong, who's a senior lecturer at School of Public Health at the University of Ghana. And there are details about his bio that you can have access to. Our second speaker is Dr. Muthoni Mathai, who is a psychiatrist and senior lecturer at the University of Nairobi. And similarly, our third speaker, Dr. Noeline Nakasujja, is the chair of the Department of Psychiatry at Makerere University. And so I'm going to hand over the floor to our three speakers, starting with Dr. Asampong.
Thank you very much.
Over to you, Doctor.
Yeah, thanks very much, Dr. Bhana. Let me try and then share my screen. Okay, there we go. Yeah. All right, so what I'm going to be talking about will be more to reiterate the need for South-to-South collaboration in child mental health. And I think that earlier on in the day, we had Dr. Patel, who has done quite a lot. And so I got the opportunity of reading some of his writings. And then not too long ago, we heard from psychology for some time now, in addition to the teaching that I do. And oftentimes I like to do self-disclosure. And so at this point, I think that I want to do a self-disclosure. And then from there, I would want to take a look at what the situation is on the ground and what it is that we can do to ensure that we can have a very good and lasting collaboration. So years ago, my student days, I actually experienced what we call in our part of the world broken hearts. And what it simply means is having been disappointed by, a girlfriend who you thought that you were going to end up marrying. And I mean, when it happened, well, the fact is that I became depressed. And unfortunately, I didn't know anywhere to go. There was a counseling and placement center on the University of Ghana campus, but I just did not want to go there to access any form of help. So reading around, I chanced upon people and got to speak to somebody who was then practicing clinical psychology. And the thinking was that, well, if I want to help many people out there, then this was the area I wanted to go into. And so I got the opportunity to enroll to be trained as a clinical psychologist. And along the line, there was the opportunity to do an internship at a major psychiatric hospital in Accra. So this was a place I was going almost every day, Monday to Friday. Apparently, there was a mate of mine who also had his office in that area and was seeing me on a daily basis entering, the gate to the psychiatric hospital. And I thought that, well, this mate of mine, if he was curious about anything, all he needed to do was to ask me if everything was okay. But he actually went to ask other mates. And the question he was asking them was if everything was okay with Immanuel. So clearly, the mere fact that I was going to the Accra Psychiatric Hospital daily basis, I wasn't seeing him, but he was. The thinking was that something was not okay with me. That was then. Has the situation changed? That's what I want us to be taking a look at now. So we observe that mental health challenges, looking at low to middle income countries generally, and particularly in Sub-Saharan Africa, has a number of challenges. In fact, there is a very large treatment gap for mental disorders that we all know. I think that Dr. William, made allusion to some of those happenings on the ground. Quite apart from that, there is some kind of work being done, but it's not that much. And so we do have not too much evidence to, as it were, fill this gap. So what is accounting for, this gap? We have few numbers of active researchers on the continent. I mean, there's a lot being done, but if you look at the gravity of the situation, then it's just obvious that the number of researchers on the continent are woefully inadequate. And in addition, the evidence that is generated usually sits somewhere. So there is some kind of disconnect between researchers and the kind of evidence that they generate and whether this evidence informs policy. So it's as if whatever we find out as researchers really does not translate into any policy. So Dr. Patel, in one of his writings, made this statement, and I thought that, look, this is a very significant statement, that mental health services in developing nations tend to imitate those in the West. And the emphasis here is that in the West, there are specialists in clinics or hospitals that treat these patients. So the question then becomes, those of us in Sub-Saharan, if you look at the practitioner-client ratio, it's just not the best. If you look at hospitals that are in Sub-Saharan Africa that are purposely for mental health challenges, very inadequate. In fact, in Ghana, we have 3 public psychiatric hospitals, and these facilities are all located in the south. So the question is, what happens to, but apart from that, the specialists who are available are not, enough. And so they are not able to meet the number of cases that come to them. So hospitals are not enough, and then the specialists are also not enough. Now, the issue of stigma is a major challenge, in Sub-Saharan Africa, to the extent that people do not just want to openly accept that a relative or a child has a mental health challenge. And so what happens is that these people are kept in their homes when in actual fact something could have been done about their situation. And then quite apart from that, the realization is that most people tend to attribute whatever conditions to, the spiritual realm, so for want of a better word, they are like, well, these people are being bewitched. And so if it happens that the thinking is that the people are being bewitched and therefore it's something in the spiritual realm, then the health-seeking behavior also becomes something that resorts to, the spiritual aspect of it. And at the end of the day, these conditions deteriorate. By the time they get to the facility, it would have become worse. That is the more reason why there is the need for us to have an innovative thinking. And this innovative thinking, I think, really fits into the theme of this conference. Having this South-to-South collaboration, for me, should be a deliberative move, something that we should consciously ensure that we are doing. And once we are able to do that, it will manifest in that solidarity among countries, so that whatever is being done in a country in Sub-Saharan Africa that is proving to work, we can actually replicate that in some other country. That really is the way to go. That also offers us the opportunity to exchange ideas, exchange experience, and then also exchange expertise. And it is at this point that I would want to zoom in on a typical example, which is the Smart Africa project. And so we know that this is purely an implementation research thing. Uganda, a site in Uganda is actually doing so well. And for us in Ghana and Kenya, we were to more like learn from whatever good thing is being done in Uganda. And the interesting thing is that when it's about implementation research, there is always the need to take into account contextual factors. And so what happened is that the Ugandan study resorted to parent peers out of the multi-family group intervention. For us in Ghana, yes, on the ground, looking at our context, the realization was that parent peers was going to be helpful. But then if we were going to use the community health workers like it had been done in Uganda, that really wasn't going to inure so much to our benefit. So we found out that, look, in the schools, we have the school health education program coordinators who have been trained to handle some health issues, usually on hygiene, about school pupils. So the thinking was that if we were to adapt these chef coordinators to be the ones to facilitate this MFG, how was it going to be like? And interestingly, that has been so well. And this is a typical example of South-to-South collaboration. And this is what I'm saying, that we want to tune our minds towards that direction, tend to look more at that direction, because that's what is going to help us. That is what is going to contribute to our respective national well-being. And so the realization is that South-to-South collaboration is and will be more important than ever before in these circumstances that we find ourselves in. And it's for that reason that those of us in the University of Ghana School of Public Health are very ready, want to, as it were, collaborate with other countries and institutions that are doing things in child mental health, because what we say is that these children are our future leaders, and we want to ensure that indeed the foundation is built right for them, so that in future they will be able to take care of us. Thank you very much.
Thank you, Immanuel, and thank you also for sharing a very personal story, indicating the importance of the availability of treatment for some very common mental disorders that many of us experience, such as depression. Let's move on to Dr. Muthoni Mathai.
Thank you very much, Dr. Bhana. It's really a pleasure. Let me first say I will not present any slides, but I will talk about the South-South collaboration from based on some of my own experiences. First of all, I would, of course, like to thank the the investigators, the researchers, and everybody who has made this possible. And of course, the National Institute of Mental Health for the funding of Smart Africa as a whole, and for our being invited as a country, as a university, to participate. One of the things I wanted to say is a bit of a historical background, is that South-South collaboration, as far as Kenya is concerned, is really not new, but has not been structured, and maybe we keep forgetting. And really, I'm glad Dr. Nakasujja is here, because we've been collaborating in mental health with Uganda for many, many years. And the Ugandans built our mental health unit. Our psychiatric department was built by Ugandans, and acknowledged Professor Chuda and others. And so we've been collaborating. Maybe we don't write about it. And that is one of the things that we have, that South-South collaboration, which has been existing, has been very poorly documented. And now going on to South-South collaboration, and I want to say that my own career path in research and capacity building goes back to the medical education program initiative, the MEPIs. And this is really where I started, and that had a lot of South collaboration. And I hope you can hear me. My internet is not very stable, but it is within the MEPI that we also started our applied for a linked grant in capacity building for mental health, which really helped us to build a capacity within our department for mental health research, to the point that a lot of our students who participated in that, who got capacity building, then went on to do fellowships and to do PhDs and have really advanced mental health research. Now, of course, I haven't said anything about child and adolescent mental health, but that was
Unfortunately, we seem to have lost Dr. Mathai.
I'm very sorry. I really want to excuse myself. My network is very erratic today. So I was talking about I hope you can hear me, the capacity building that was born out of the MEPIs, and how it is really strengthened the South-South collaboration. Of course, a lot of it you can say was not really just South-South collaboration, but triangular collaboration, or what has been called the high-income country, with partners in the US and multiple collaborations on the ground. And even the SMART is really one of those triangular, you could say, corporations. But the other thing I wanted to talk about the SMART on the ground and how we have collaborated with our partners. I really liked what Immanuel said, that, you know, we don't have enough specialists in our setting, so that we can have like specialists in child and adolescent mental health, but rather that we have to be everywhere, more or less. We are the specialists in adult mental health, in child, in adolescence, in gender. And so we find that you can't really afford to have those child and adolescent mental health specialists. We have to be everywhere, because that is the capacity that we have. And of course, Now, going back to this child and adolescent mental health and the SMART and how we've been collaborating with Uganda, starting from the manuals. We actually moved, when we were doing the MFG manuals, we depended very much on the original manual from the US and also on the adaptation that had been done by Uganda, because Ugandans and us are very close culturally. We have lots of history together, lots of journeys together. So we found that there are very many similarities. And even when it came to implementation, they have community health volunteers, we have community health volunteers. So we have been able to take advantage of the Ugandan intervention and the implementation ahead, and even to cut back and ask questions. And this has been very good, because we were asking questions to people whose setting was so similar to ours, you know. Even when we went to their schools and we came back to the Kenyan school, you say, yeah, the Kenyan schools look very much like the Ugandan schools. I hope I'm not going to be kicked out by my internet again. But and interesting is that we have the South and South collaboration is also a very regional thing. We've had very little, and this is the future will be also because of the structures, you know, that countries which are in the same region are more likely to have similar structures than countries which are further away. Like we don't have that shapes like the Ghanaian have. Our teachers do have counselors. And so we went in our implementation, the Ugandan with peer parent community health volunteers. At one point, we considered using teacher counselors. But after talking to parents, we had a lot of consultations with the stakeholders and the parents. The teachers said, no, the parents said, no, we don't want teachers. We don't want teachers because teachers already have their own biases about our children, you know, and our child will be there and the teacher will be saying, oh, but that is a child from this family. They don't do well anyway, even in school, even the parents never did well. So we actually found it, and we had really favored teachers. We thought for continuity, it would be better to have teachers, but obviously the parents had other opinions, and it has worked very well for us with the community health volunteers and the peer parents. Now, as far as the future is concerned, I think the future of South-South collaboration depends more on us having more structures outside activities. It seems like we come together when we have an activity like a project like this, and after that we fall apart. So the future depends on us having a sort of association, even in child and adolescent mental health, which is beyond activities. Where do we go from the SMART? How are we going to scale up? We would like to scale up, and our scale up would, of course, depend on the policies. We've been engaging with the Ministry of Health, the Department of Mental Health, with the Children's Department. We had a lot of stakeholders who are in the policy field. But if we're going to continue a South and South-South collaboration in child and adolescent mental health and in other forms of mental health, it depends on us going beyond projects, beyond a triangular system where we only come together when a high income country has a project and then brings us together. The question is, how do we do this? And I want to leave this question in the room. How can we get beyond activities to collaboration that is exists, and we can call upon each other when we need each other, and we have continuous forums where we deliberate, where we dialogue. Can we have these dialogues outside of activities? Thank you very much. I hope I haven't taken too much time. Thank you. And sorry about the interruptions. Thank you.
Not at all, Dr. Mathai. That was you were most of the time you were fine. So thank you very much, and you expressed your thoughts and views very clearly, and lots of food for thought here. So let's move on to the next speaker, Dr. Nakasujja.
Thank you very much for the introduction, Dr. Arvin. I'm very excited to be here on today's conference. I would like to thank the organizers of this meeting for putting this together, despite the limitations that we have had to adjust with the onset of COVID. I would have loved to see each one of you individually and to share this live, but this is the best that we can do for now. But I'm still excited to be here. I would also thank the organizers for having given the invitation to me as a representative from Makerere University to talk about South-to-South collaborations, but in particular for child mental health. So I would like to begin with, part of the work that was earlier done in Uganda in the 1960s. Uganda at that time had a lot of, brewing research in child mental health. For some of you who may be, child developers, know that Mary Ains work on, child attachment. Actually, some of the parent diets, child diets were collected from Uganda that contributed to the development of the attachment theory that states that if a child is grown up in a secure environment with a caregiver that is fully dependable, that child then is able to grow and explore the world. And previous speakers, including Professor Vikram Patel, mentioned this in his earlier presentation. But it was rather unfortunate that with us showing that, a lot of research can be done on child development within here, Uganda, that kind of crumbled with the onset of wars in the 1970s through the 80s, and everything, ground to a standstill. And it wasn't until the late 90s that research into mental health, specifically for children, was again reawakened. And a lot has been done by various groups in child mental health. As we may know, a couple of those may have been either individual researches or north to south collaborations. But apart from Smart Africa and a few others, I'm not very aware of many others that specifically look at child mental health only on the African continent and are involving, cross-country participation. So in Uganda, part of my talk will talk about the, what happens at the department as regards child mental health and collaborations. And then I'll talk about the other collaborations that are available for inter-country, a part of which Dr. Muthoni has talked about. And lastly, I'll specifically speak on one of our projects that is currently trying to develop capacity for child mental health and training, as well as research. So if I could speak about the departmental collaborations. Dr. Muthoni talked about how we've always been working together in the training of students, not so much for research, but certainly we collaborate on examination of students, validating each of our curricula. And that has happened with the University of Nairobi, with the University of, with Moi University for Nairobi, as well as Muhimbili University in Tanzania. We've also worked with other universities down south, Cape Town, University of KwaZulu-Natal, where we, at least on the academic point, of doing things, we actually collaborate in ensuring quality of our curriculum. As regards research, there are a couple of other universities that have tried to work with us. Collaborations to south may not cross across countries, but they do cross across institutions within the same country. And for some of those have explored things like HIV, child development. They have looked into alcohol use among children in Uganda, which is alarming, but actually happens for whatever reasons that has predisposed our children to such problems. And those are led by some of our departmental faculty here at Makerere, including Dr. Joyce Nalujja and Dr. Catherine Abo, who also is trying to work on a child development clinic to support child, growth in ensuring that the environment, as one of the previous speakers said, and I think it was Vikram, that we need to make right the environment for the child rather than putting the child proper. If we make everything okay within the child's environment, then they will grow up fine. So when it comes to the collaborations that have existed south to south on a university-wide basis and also across our continent, programs like Thrive, Happy, MEPI, they have, these have been training grants from Fogarty that promote research and mentorship for faculty to build capacity in this staff so that they can do their own research or develop in their specific areas. And some of my colleagues have actually benefited from funding from these researchers in furthering their researches within child mental health. And specifically, I think that would be Dr. Catherine Abo, who is a child psychiatrist here. We've also had collaborations. One of the objectives was for us to talk into collaborations that are kind of beneficial for whoever is involved in that collaboration. Now, we've had for a long time, and we continue to have south to south collaborations that are rather north to south collaborations, but for which there's more of a giving on our side with the opportunity for experiences of things that the north may not have ever looked at or been able to experience, usually through trainings that are offered to students or even for research for conditions that may not be easily researched in the north, and yet are pertinent issues that for which we need to find solutions. So we've done a lot of that over time, but I specifically just want to pick out one of the collaborations specifically for the Department of Psychiatry, where we have a student exchange with the University of Vermont that allows its students to come over here for training, in child mental health as well as other mental health problems. But also we were able to come to a memorandum of understanding where they could also participate in the facilitation of our students' training through tuition support, as well as having a time to move over to Vermont and experience how clinical psychiatry is practiced over on the other side of the continent. And all that was going well until COVID came. And so the students from Vermont can't come, neither can ours go over the other side. But I felt like that was an equitable kind of collaboration for north to south. But these things could also happen with us collaborating with other universities on the southern side. Dr. Muthoni says, our cases, we kind of have a similar culture and presentation. So having moved across the border as an external examiner, I agree maybe there wouldn't be much for them to learn from us other than them praising our National Psychiatric Referral Hospital as the cleanest and the best. I think south of the Sahara, maybe apart from some South African institutions. So, however, we could still have more collaborations that way with student exchange. Our faculty do move over through training, like I had said earlier, but usually not much as regards to the students, and the prohibitive factor always being usually the finances. But we've also become innovative in doing collaborations over Zoom. For example, we do have a case conference that we hold with about 5 universities, some of them on the continent, while others are out of the continent, where we actually discuss cases that are usually in the field of child mental health or from psychology, learning experiences of how patients present and how they are managed, and appreciating the differences in human resource or the limitations that we have here on the African continent with whoever it is that may have joined in on the call. And I feel those are usually very beneficial because either party learns, be them in South Africa or be them in Kenya, of what it can actually happen in how a patient can be managed. The other thing that I think I need to talk about is the child GRF. We summarize it, but in full is the child mental health in HIV impacted low resource settings in developing countries. Global Research Fellowship, it's a D43 training program that we have. I'm a fellow PI together with Dr. Fred Sewamala and Dean Mary from Washington University, in which we train fellows in creating, more research into the field of child mental health, specifically with HIV in the picture. And it's really a very good program for which we are into our second year. In our first year, we got 7 trainees joining the program after receiving, I think, over 50 applications, and we really had a hard time in selecting people who could do research within within our setting for this rather very neglected field, because there are not many researchers that specifically focus on children and children mental health. So this is a very good program. And the way we made it a south to south kind of collaboration is to ensure that we went beyond Makerere University, which was part of the primary applicant as the African continent application, to involve other universities where we felt there was capacity for us to build on these individuals. So south to south may not only go beyond country, but also doing it within country, I think is very useful for ensuring that there is, we build a crop of individuals that can further child mental health on the southern continent. These trainees have the opportunity of interacting with trainees over in the US or from other countries. And we're hoping that this will help to build relationships that can further child mental health research, not only in HIV, but as well as in other fields. And we are seeing that is happening, and we're really excited about it. We just got our year 2 fellows joining the fellowship, and our hope is that by the time all these fellows are done with their training, we will then be able to have them apply for research grants from the NIH that may not only be based within country, but they are free to then form collaborations, south to south or north to south, or multiple research collaborations that can further mental health. So, and as we continue to go into the future, we hope that we will have, and we've already actually done that, tried to apply for grants that involve multiple countries south to south, even when we may have a global north collaborator, that there is an inter-country participation of researchers, and that is encouraged very much. I'll stop here. I've used up, I think, about 12 minutes. I'd like to leave room for questions. Thank you very much for listening to me.
Thank you, Dr. Nakasujja. So I think there's some questions already in the chat, but let me quickly go through. Starting with, if we can have all the speakers with their video cameras on, be great. That's fantastic. And we're just waiting for Dr. Mathai. There we go. So, just beginning with Immanuel's presentation. One of the questions that occurs to me is that clearly there's an issue of human resources, that you don't have enough specialists, you don't have enough trained clinicians, etc., in common to all of the three countries that we are talking about here. But if you look around, you recognize it's a universal problem. That there's an issue in virtually every country. So it's really about the question to all the three panelists is and given the evidence around task sharing, should these contexts not focus a lot more on ensuring, and I know that I refer to Immanuel's presentation because he talked about the treatment gap, that task sharing might be a really good response to managing treatment gap issues. And so just your comments about how do you think each of these countries in terms of collaboration might advance task sharing?
Well, so for us in Ghana, over time, the realization was that if we had a practitioner who was moving into the communities, that would be more helpful. And so in 2012, when the Mental Health Act, became a law, the emphasis was to move from institutional care to a community-based approach. So then the idea was that there was the need for community mental health psychiatrists. That was the terminology, for them to now move to the community, identify households where there are challenges, and if it so happens that there is more than one person, then these are the people who really can offer the help. But then again, the challenge is that not many people are willing to move into the area of psychiatry. And that's why perhaps I make reference to my experience when my mate was asking if everything was okay with me just because I was, entering the psychiatric hospital. And so I think that it may be important that we shift some focus on trying to destigmatize, mental. Sometimes, depending on how you conduct yourself, people tend to think that, hey, perhaps you are also picking up, some of the problems. So it's a real challenge, and I think that we need to perhaps turn our attention to trying to get a lot more people to move into that area of training. So at least we can have quite a lot more of people. And if we were doing it that way, then if these people are moving into the communities, that should be helpful, at least in our context in Ghana. Thanks.
Dr. Muthoni, do you want to respond?
Yes, I would like to say something, because this the thing with task sharing is, of course, we are not going to get specialists in mental health to cover our countries for quite a long time, and this is very clear. So we're going to really depend on task sharing and shifting, and my thoughts on this is that one of the things we've had with community health volunteers is that they are very much needed for everything else. And mental health is not a big priority so far in our countries. It's HIV, it's diarrhea. And a lot of them shift depending on which, where there's a project with money. We do have now about volunteers, which includes mental health. But again, until you find that, until there's a project and you come in and tell them, yeah, we've had training in that, it's not very, they're kind of overwhelmed sometimes. So I still think that teachers have an important role, even though our parents were like multiple family group led by teachers was not so acceptable. And yet teachers have the capacity to identify but only if they're trained. In terms of child and adolescent mental health, I think we can still task shift to teachers, at least to recognize, to know what are the kind of interventions as teachers. That is my thought on that, and the role of the schools as the area where children spend a lot of time in schools. Thank you.
Thank you, Dr. Muthoni. Dr. Nakasujja, do you wish to respond? Yeah, I think you're muted.
Right. While I appreciate the challenges we have as regards human resource for mental health, and maybe specifically for child mental health, I may be from the other school of thought where I've faced challenges with that task shifting of roles to cadre that may actually end up doing more harm than good. That said, I'm not saying task shifting is not impossible. When we do identify cadre that could be well trained, even if it's for a shorter period to take on certain roles, yes, they can help in performing that role. So specifically, I would like to talk on a program that we have on child and adolescent mental health training that was conducted here through our National Referral Hospital, Butabika, with that from London that helped to improve on the human resource for child mental health. But it was specific in choosing people who were, at least a nurse and above, and they did have a very long-term training. So task shifting with just the task shifting of tasks, I do not agree with, but with some training, yes. Yeah, especially with things to do with mental health, it can get complex sometimes.
Yes, so typically the model of task sharing we're talking about is there must be training and there must be ongoing supervision. And as you correctly point out, that it's some mental health issues are beyond the task shared individual. This is merely to sort of suggest that for most people, very ordinary issues around depression or anxiety, that a task shared solution might be a better solution than just trying to channel everybody to a specialist. But nevertheless, I'm going to go to some of the questions that have now appeared. So let's start with William asks, he would love to hear thoughts from the panel on what can be done to strengthen existing South-to-South collaboration, but importantly, building new collaborations. Anyone wants to take that?
Well, on my part, I think that it's been an interesting, what we currently have has been very interesting. There will be the need for us to have some lessons, so at the end of it all, if we can have an evaluation of how the collaboration has been like, that should be very helpful, because then we are able to identify the pluses and the minuses and, put in some corrective measures. That way, we would be, as it were, strengthening whatever good things there are, for us to move on. Over.
Thank you, Immanuel. There's just a related question, and I'm going to read them in a combination just so that you get the flavor of it. I asked the question, given the strong collaboration between Kenya and Uganda, what do you believe is needed to ensure further enhance collaboration? And Fred wanted to build on that, and he's asking the question, what have you found to be the best frameworks and ingredients for longer-term collaborations, both in research and teaching? In other words, what are some of the longest collaborations you've had, and what is unique about those collaborations, knowing that many do not last beyond a specific program activity funded period? And I believe that Dr. Muthoni did refer to the fact that we need to have collaboration that go beyond the projects. Anyone care to respond to that? Or is it too long? You want me to repeat it?
No, it's okay.
I could give it a try, particularly when it comes to our collaboration, like the collaborations that have lasted longest between us are academic, like Dr. Nakasujja has said. We have ongoing exchange of examiners and curriculums and things, but this has not flown over in terms of a South-South collaboration, in terms of other forms of capacity building or research. And that would have to be a very structured regional thing, like we have our East African region, community development, which is structured. And maybe what we would need to have is a structured regional kind of association. And I remember the most other projects where we really had a long ongoing is when we had the people like bringing us together. So we had continuous interaction, continuous activity and capacity buildings. But that seems to have now gone in a different way. But so it would have to be like really a structured thing. Maybe we could replicate our East African community, for example, and structure ourselves, because that includes other countries as well with whom we don't have any kind of collaboration, but that has to grow from somewhere. And maybe this collaboration we have in this SMART would be a starting place to start such a thing. Maybe let's hear what somebody else has to say on that.
Right. Yeah, so like Dr. Muthoni has said, one of the strongest collaborations we have really are academic, and that have worked very well because of a mutual respect between, universities and having a kind of similar levels in you know, in the quality of students that are expected for the East African community. So while it doesn't happen for mental health, and it is something that has just been proposed, for example, for us to have a, you know, an East African, Southern Africa, you know, region kind of similar exam. The surgeons are doing that. They have, you know, for you to, you know, graduate as a surgeon of the college, then you sit uniform exams, and they arrange this, you know, across the country, south to south. I think that's a good thing. The physicians also do the same thing, though I don't know about them having an exam, but I know that they work very closely together in having a unifying conference and setting similar standards. So I think moving forwards for child mental health specifically, that would be something that we would specifically need to, you know, see how we harness to make long-lasting collaborations. That is on the side of the training. When it comes to research, I think the relationships we build with people when we get to, you know, meet with them should be developed further through, you know, working on similar projects, but with one being very intentional about, you know, this cross-country kind of work, given that sometimes the funding is country specific, and maybe it may not allow for one to cross over, unless of course it was a worldwide or like a Fogarty research, which allows for north-south. They may not mind how many numbers of individuals you bring on the team, but for as much as possible, for us to look out for opportunities like those ones that could allow for continued, you know, interfacing of the south to south countries.
Thanks, Dr. Nakasujja. I'm reminded that we have a couple of minutes before we have to stop. There are some other questions about policy influence outcomes, how we can harness current relationships with Washington University to get more specialists into the field of mental health. I think some of you have already mentioned that, you know, the relationship with universities is particularly fruitful and helpful in building capacity. Are there, you know, for example, plans to bridge the gap in building human resources? If it's already been tried in Kenya, what lessons can we learn from other Sub-Saharan countries? That's from Jennifer Natabi. So I want to thank you all for your contributions and for your readiness to engage the conversation. One of the points made by Dr. Nakasujja is that the collaborations have to be equitable. And I think I'll stop at that point and hand back to the program chair.
Thank you so much, Dr. Bhana, for moderating the panel. Thanks to our panelists, Dr. Noeline, Dr. Muthoni, and Dr. Immanuel. That was excellent. Now I would like to invite Dr. Fred and Dr. Osgei to give us their closing remarks.
Wow, what a first day, packed with rich information and engaging discussions around child behavioral health and South-to-South collaborations. We're very thankful for Chancellor Martin for joining us and our distinguished speakers, Dr. Patel, Dr. Gordon, Mr. Williams, for their contributions. We would also like to thank our panelists who shared with us findings from our scale-up study in Uganda, and also their insights about how to strengthen South-to-South collaborations and learning. Our big thanks to our MCs, Dr. N and Dr. Proskovia, and our moderators. We have another exciting day tomorrow, starting at 8 a.m. Central Time. We'll have the opportunity to hear about Washington University's partnerships with universities in Sub-Saharan Africa from Dr. Dirks, who is the Vice Chancellor of International Affairs at Washington University. Dr. Bengana will join us to talk about WHO priorities around child and adolescent mental health. We'll hear about study implementation and results from our Smart Africa, Ghana, and Kenya teams. And we'll also hear from Dr. Geeta Bansal from Fogarty International Center at NIH on training a new cadre of researchers from Global South. I would like to thank you all for attending. You will see a link on the chat for the evaluation of day 1 of our conference. We would really appreciate you taking the time to give us some feedback. And we look forward to seeing you again tomorrow and wish you all a great rest of your day, evening. Dr. Fred, if you have any concluding words, please feel free to hop in.
No, just to say thank you. Thank you, thank you, thank you. I know our colleagues in Kenya, it's late. I know our colleagues in Uganda, they have been attending in groups, it's also late. I know our colleagues in Ghana, it's late. For sure, Arvin, I know it's late also in South Africa. But thank you so much for staying on, and we look forward to seeing you tomorrow. Thank you so much.